Hey everybody, today we are going to be talking about asthma. Remember that you can read more in depth about this in chapters 11 in your Honan book or chapter 21 in your ATI MedSurg book. We're going to just be hitting some of the highlights and areas you need to focus on. So the epidemiology of asthma, it can be variable and recurring symptoms, airflow obstruction, and bronchial hyperresponsiveness. This is typically triggered by an overreactive autoimmune response. Inflammation is going to be a key underlying feature. So when you're looking at treatments for your patients, again, we want to think about opening up, dilating, and reducing inflammation. Sometimes patients do have a genetic predisposition, being IgE mediated, and importantly have a strong response to allergens. The patho, make sure that you understand this, like I said in the last slide, it is an immune hyperresponsiveness. It could be to allergens or irritants. It will cause bronchoconstriction, diffuse airway inflammation. So you're going to have swelling, and over time have some remodeling of the airways, which just lends to making the asthma worse over time if it's not properly managed. This is a good side-by-side comparison of a normal lung versus an asthmatic lung. Some triggers, again, it can be anything from air pollution to tobacco use, secondhand smoke, medications, additives, allergens, workplace, occupational hazards. Respiratory infections can make it worse. Constriction, with changes in temperature, cold air, exercise, stress and emotions, or strong odors. Risk factors, the aging process itself can lend to changes in the lungs, family history, and again, allergens and irritants, which can be either environmental, chemical, or smoking. And the next slide, we'll talk a little bit about the relationship between GERD and asthma. And you can spend a little bit of time on this. Just know there's more research that's showing some link between the two. Promotion, from the aspect of a nurse, you want to help your patients understand what the triggers are and to avoid them. Prevention through proper vaccinations of flu and pneumonia. Regular exercise will actually help promote ventilation, maintain good cardiac health, and these patients may need to be pre-medicated before they actually engage into exercise. They need to watch use with certain medications like NSAIDs, aspirin, non-selective beta blockers, and cholinergics, just because it can actually trigger the asthmatic response in the body, temperature changes, and the use of warm humidifiers and such to help dilate, and make sure that they're actually using their medications properly in terms of their inhalers. The manifestations of asthma can be from, in general, coughing, wheezing, shortness of breath, breathing rapidly, complaints about a tight chest. Goals with patients: want to help manage their symptoms, keep them calm, watch their pulmonary function, prevent recurring exacerbations, proper use of medications, and making sure that they're well educated, that if they especially are using the medication more than prescribed, that their asthma could be getting worse, or they may not be using the medication properly. So that's going to be part of your investigation as a nurse. Obtain their history to get a sense of how well controlled their asthma is. So some labs you may want to look at depending on what they're being treated for. especially just to possibly rule out if an infection is the cause of worsening the asthma. And we'll talk a little bit more about the actual diagnostic on the next slide. So with pulmonary function tests, or PFTs, spirometry will actually measure how much air you can actually, when you inhale, breathe in and exhale, and how fast you can exhale. For that, what's going to be important is understanding the ratio between the forced vital capacity, or FVC, which is the amount of air that's exhaled from a full inspiration to a full expiration when the lungs feel completely empty. And that's divided by the forced expiratory volume in the first second, so the FEV1. Typically, here decrease by 15 to 20% is common in asthmatics, and increase by 12% after dilators are used can be a sign of diagnostics, but typically ranges less than 70% do warrant some issue with pulmonary function. So again, percentages below 70, we're perhaps seeing some issues. When you're actually dealing with a patient, if they're having problems with asthma, you want to talk to them about positioning, oxygen, doing cluster care with them, and again, encouraging them to get their vaccinations. So peak flow meter becomes standard use with asthmatics, especially if there's persistent asthma going on, and it just kind of gives them a sense of how well managed their asthma is at certain times. And so everybody's personal best is going to be different from each other in terms of what are good ranges. Most individuals will hit their peak ranges between the ages of 30 and 40, but ranges between 400 to 60 liters per minute typically are within good range, but everyone will have their own personal best. So make sure you do understand how to use a peak flow meter, and what you need to do to educate your patient in terms of contacting their physician. Further education, there is 3 zones: green zone, yellow, and red. Green, good control; yellow, caution; and red would be medical alert. And it all has to do in terms of percentages of a patient's normal rate. So the greatest complication that our asthmatics can suffer is status asthmaticus, or an asthma attack. This is basically when somebody's experienced asthma and they're not responding to conventional therapy. There's also a decrease in the bronchial diameter and ventilation perfusion abnormality. Sometimes episodes can be brought upon by hypersensitivity to aspirin. So again, a few slides back talked about patients and certain over-the-counters or medications they should watch because it can make the asthma worse. And again, there could be different triggers that set this off. With these patients, typically there's no correlation between the severity of the attack and how much the patient actually wheezes, but unfortunately the greater the obstruction, wheezing might actually start to disappear. And when that wheezing starts to disappear, it can mean that there's impending respiratory failure or cardiac arrest that could potentially happen. During this time, studies in ABG analysis may show respiratory alkalosis, but that can certainly change during the progression of the attack. So priorities is try to maintain patency of the airway, help with ways to facilitate gas exchange. Nutritional intake is going to be important with these patients over a period of time. How to slow the progress of the condition with these patients, and to give them information of how to prevent future attacks. Different medical management, either nebulized, short-acting, beta-2 adreneric agonists, theophylline, steroids, epinephrine, and obviously supplemental oxygen and IV fluids to hydrate the patient. High-flow supplemental oxygen. The best way to have an actual meter dose of how much oxygen you're giving a patient is you'll use a Venturi mask, or it can be used with a non-rebreather mask. Others, magnesium sulfate can help induce smooth muscle relaxation. Patient typically is hospitalized, and if they are actually in this state, they're usually in the ICU. And if necessary, if there's impending respiratory depression happening or failure, that they might need mechanical ventilation to help support breathing. Overall, depending on the type or severity of the asthma that they have, not type, but the severity, will kind of dictate their pharmacological regimen. Normally, for situational asthma, seasonal, sports-induced, first line is going to be a short-acting beta agonist to be used as needed. For those who may have persistent asthma, there may be an introduction of anti-inflammatories, because again, remember the two main big issues that we're having is that bronchial constriction and also inflammation. Most physicians, once they get a patient on a regimen, if there is some improvement seen with the asthma, they'll try to back off on the medication, simply because they don't want the patient to become dependent, and also the lowest dose possible is going to be in the best interest of your patient. Different medications, bronchodilators. These are going to be as needed or rescue inhalers, so Preventlin, albuterol. This is what somebody's going to be used kind of as that quick relief as needed. Inhaled corticosteroids, anytime a steroid is used, we need to teach patients about rinsing out their mouth. With all types of meter dose inhalers, a spacer is used to help prevent thrush and also to get the most amount of medication into the lungs. Other bronchodilators, Atrovent is another one that can be used. Long-acting beta adreneric agonists, they are typically need to be used in combination with corticosteroids. There's a black box warning label that there's an increase in asthma deaths when they're used alone, so they are not used as monotherapy. Because of this, a lot of times patients will use the combinations, and again, the combinations do have a steroid, so you need to remind patients to rinse their mouth. And spacers also help to prevent thrush. Anti-inflammatories, if they are prescribed, and some of them are oral, so this is PO by mouth, your Singulair. Typically, if patients are on both bronchodilators and anti-inflammatories, you want to give the dilator first so an anti-inflammatory can be absorbed more effectively. And again, like I said, with anti-inflammatories, that would be used with patients that have a little bit more persistent asthma that goes on in conjunction with using that rescue inhaler. So with a meter dose inhaler, make sure you Can educate a patient in the proper way to use one. And know your parts, canister, plastic holder, and cap. And again, further teaching points. And here's the thing too, and this is why a spacer again is really important to be used, because even with perfect technique, you only get about 15 to 20% of the medication actually in the patient's lungs. So again, a spacer may be necessary. And here's information about a spacer. And you can pause this if you want to spend some time reading it. And so remember with asthmatics that if the wheezing starts to go away and their lung sounds are quiet, that's not necessarily a good thing. It is an ominous sign that a patient is possibly going into respiratory failure. You want to always be aware of respiratory status of asthmatics, and even whether you watch this before or after COPD, there's a lot of crossover. And so respiratory status for these types of patients should always be priority, whether it's patency or helping with that perfusion or ventilation is going to be typically priority one with these patients. So that's it. If you have any questions, please use the question board.